I'm just trying to recapitulate whatever I studied in emergency medicine by just recording myself. And I've been taught by Dr. Naman Agarwal in DAMS this whole topic of emergency medicine. So I've made the notes of only those parts which I felt were important or I was not well versed with them. So I'm just quickly going to read my emergency medicine notes. I revised what the notes that I made yesterday, and now I'm going to revise whole of this that I've been making notes of. I've made previously these notes, so I'm just going to revise it. Okay, so yes. Okay, emergency medicine, as the name suggests, emergency medicine is all about dealing with the emergencies, and emergencies, every system has an emergency. Okay, so before doing that, let's begin with the most common scenarios. And one of the most common scenario is if a patient comes to us and he is not responsive. Okay, so the patient he comes and we are going to check his responsiveness. If the patient is responsive, okay, then we are going to evaluate further. Okay, if the patient is not responsive, and we are going to see whether the patient is breathing. If the patient is breathing, okay, then breath can be abnormal or it can be, or breath can be abnormal, or abnormal over here can be even absent. Okay, both are put under the same stem, and breathing can be present. So if the if the breathing is present, we are quickly going to put the patient in a recovery position, and by this we are going to prevent any kind of aspiration. Okay, so always put patient in recovery position so as to prevent aspiration. If the breathing is abnormal or it is absent, we are going to check pulse. So after responsiveness, it is breathing, and after breathing, we are going to go for pulse. Now, pulse, we are going to look for central pulse, that is carotid pulse, but this step is considered optional because a patient comes in emergency. You don't have time, you have to be swift in action. Okay, so if you think that the pulse is abnormal, or one examining doctor says that yes, I can feel the pulse, while the other says no, I cannot feel the pulse, so that means that the pulse is doubtful. So in that scenarios, the pulse is always considered to be absent. Okay, now that is why checking of pulse is considered to be an optional step, and we are never going to see the pulse in both the sides. We are going to see only on one side. Okay, and what is the maximum time duration for which it can be seen is 5 to 10 seconds, and not beyond that. So we need to be really fast. We cannot keep examining the patient. We need to begin the intervention. Okay, so for 5 to 10 seconds, we are going to see. Now, after this, if we see that the pulse is present, then we are going to give assisted breaths to the patient. If they are absent, then, or if the pulse is doubtful, as I said, then we are going to begin with chest compressions. Okay, so this was all about the responsiveness in the emergency. Now, the next point over here is carotid pulse if it is present. Okay, if carotid pulse is present, we are going to start ABC. What is that? Airway, breathing, and circulation. If the carotid pulse is absent, we are going to go by CAB, that is circulation first, then airway, and then breathing. That thing has to be done. So after CAB, we are going to go for chest compressions. Okay. If carotid pulse is present, then very normal ABC. If absent, then try for CAB more than the other things. Then airway assessment. Airway assessment, breathing, circulation. Now, the first thing in emergency is that you should understand that management will uh, always begin with something that is going to kill the patient first. Oh God, this. Huh. So treat first. Oh, okay. Treat first, which kills first. Okay. So only when we are going to treat first that thing that is going to kill the patient first. So only when the ABC is stabilized, then we are going to go for D and E. What is D? D is disability limitation, and over here the disability is mainly the neurological disability. And then the E is exposure and the environment. In trauma with airway plus cervical spine protection is also a component that we studied in surgery. That whenever trauma की बात होती है, we are going to talk about along with airway, cervical spine का protection is a mandatory thing. Then resuscitation. Resuscitation. Now there are two types of resuscitation, that is vertical and horizontal. So vertical resuscitation, it means that there is only one provider who is going to go from step A to B to C to D to E. Whereas in horizontal, all the parameters beginning from history to resuscitation, they are done simultaneously, and this is generally there in a tertiary care hospital where there might be more more doctors present in the emergency, so they can quickly, one of them takes history, one of them does something else, like okay, whenever there is a call day of any unit, that unit's JR, SR, all are present under one roof. So that's how. So if like that scenario is there, then the intern might take history quickly. JR1 can begin the resuscitation, and then JR2, JR3, all under the guidance can work together. JR3 never works, no problem. Okay. Now, preparation and anticipating for failure. Now, yes, you need to always, it's not that however great doctor you may be, you should always be ready for failures. You should always be accepting in nature to your failures. So, preparation, you need to prepare for that and be ready. Then, what is rapid sequence intubation if the GCS is less than 8? It warrants an airway protection. Now, GCS less than 8, that comes under severe brain injury category that we have dealt in later part of this discussion. GCS I have not written down because GCS is one of the most common scores, and I felt that okay, I might just remember, I might be remembering, and I'll be able to recollect if the question comes and if I have to calculate GCS, so I have not written. Okay. So, though airway is patent, but GCS is less. So, in this also, you need to go for intubation. So, there is a possibility that the patient's airway is patent, okay, and but GCS is less. So, you have to go for intubation. It's not that ki airway to theek hai, so why to like give the patient, any assisted breathing or any intervention. But decreased tone of airway causes why is this there now not but actually I have written a wrong conjunction here. See, whenever GCS is low, okay, that means neurological deficit is setting in. If there is neurological deficit, so the sensory impulses will be sluggish, and so would be the motor response. And if the motor response will be sluggish, then the contractions of certain viscera, which is essential, or which is uh, very important, that can be compromised. The contraction and relaxation of that particular viscera will be compromised. So one of them is your tongue. Okay. Now, tongue can fall back due to less tone, and if it is going to fall back, then it will lead to airway compromise. Now, rapid sequence induction, what is it? It is what? We have to quickly intubate the patient. It is the method of choice for emergency intubation because induction and paralytic agent, they are given together. Okay. In anesthesia, we study, okay, induction agent and then later paralytic agent. No, we don't have time in emergency. We need to give induction and paralytic agent together. That is the crux of this rapid sequence induction. Then, um, okay, because why is it so? Because when a patient presents to the emergency, he or she is not fasting. He is not present in a fasting state. So, uh, like in other scenarios, when a surgery is taking place, you are going to give induction agent, then you are going to give paralytic agent, and the patient is going to, I mean, uh, the patient is then the surgery is performed, and so we can have a time gap between induction and inducing paralytic agent. But in emergency, you don't know the status of the patient, what he has eaten and what he has not eaten. So if there will be a gap in both of these things, then there will be chances of aspiration. Okay. So in rapid sequence induction, both the things, they are given together. Now there are 10 steps, 10 P's that are followed in rapid sequence induction. These 10 P's are very difficult to remember, but if we remember it practically, then we can. P is what? What is patient? Now indications of intubation. You need to identify that, okay, this is the patient and he needs intubation. That is the first thing that you should look into. Second is preparation. Then you should have an equipment, you should have a personnel to use that equipment, and then you should also be ready to accept failure. So you should always have a plan B. Like if this doesn't work, how am I going to do it? Okay. Then position. Now position, how what will be the position of the patient? It will be sniffing position, and sniffing position is only for lean and healthy people, but for obese people it's a ramp like position. I don't know what is ramp like position. Maybe like a gate or a ramp, they are going to incline the person or something like that. Khair. Then comes the pre-oxygenation. So after this you are going to pre-oxygenate the patient, then you are going to give pre-treatment. Pre-treatment over here is actually like if any fluid, you should just start giving the fluid, etc. Then push the induction agent, then you are going to give the paralytic agent. So both these two components, they are actually a part of rapid sequence induction. Then you are going to place the ET tube, and then we are going to check the placement, so that what if he starts breathing and just the tube dislodges. So then there will be a post intubation care. Now post intubation care is again a part of, anyone can do that. I mean, anyone in the sense, not you don't need a specialist over here, you don't need an anesthetist over here. And people posted in emergency, they do that. Okay. Now, choice of induction agent. Now, choice of induction agent. See, ketamine, propofol, midazolam, etomidate. All of them, they look the same. In the options also, there are sometimes they juggle between these options and ask something or the other. So, in ketamine, the only thing that you need to know, ketamine causes hypertension. It is going to look after the pulse of the patient. It is going to increase the intraocular pressure, but it will have no effect on the intracranial pressure. Now, propofol is cerebroprotective. It can cause hypotension. Ketamine was causing hyper, and propofol also causes myocardial depression. Midazolam is always given with or without fentanyl. Etomidate is cardiostable. That is the only thing I remember from anesthesia. And little adrenal suppression can be there. It also causes little adrenal suppression. So yes, these two are the important points over here. Now quickly moving to rocuronium. Rocuronium is what? Rocuronium is a paralytic agent. Okay, rapid sequence induction may this is also used. Now what is plan B? Now plan B is what? Do you have an expert that okay? If you have the plan B is you are going to refer to an expert. Like medicine people can take the help of anesthetists. I'm not sure whether they come or not, but still. So we need to look for the expert. If expert is not there, we are going to give airway adjuncts. What are airway adjuncts? Airway adjuncts can be boogie or It can be supraglottic airway devices, that is laryngeal mask airways. They can be given. Now, airway adjuncts, if even that is not successful, surgical airway, that is surgical cricothyroidotomy, that is generally the last. So all these things they come under the category of plan B. Now, primary survey. What is primary survey? You are going to go for A, B, C, and once A, B, C is complete, only then you are going to proceed to D, and then secondary survey is done. Okay. Now, airway. Now, let's talk about airway. A is for airway. Over here, it will be COPD, vomitus, or any mechanical injury. So, these are the things where you need to look into the कि airway ठीक है कि नहीं है. Sometimes the patient might have COPD, patient might have collected vomitus in his mouth, okay, due to decreased tone. So a patient's vomitus can also be trapped there. There will be mechanical injuries as well. Now, breathing. Breathing is another breathing problems could be associated with ARDS or severe pneumonia. Like in both the scenarios, patient can present with dyspnea. Then circulation. Circulation, what is the thing that circulation related thing for which the person will come to the emergency? It was shock, profound shock. Then disability. D is disability, and over here disability will be decrease in GCS. Okay, GCS will be decreasing. So what we are supposed to do? A decreasing GCS first, we are going to maintain the airway. And E is expected course of action. Expected course में क्या होगा? Expected course is like अगर borderline patient है, then we are going to go for CT scan and we are going to send out to other hospitals. Like we should be prompt enough and also intelligent enough to make referral. Okay. If there is another expected course is caustic injury that can lead to airway damage. So a person can go for can collapse very fast. So in that case, we have to be ready with the surgical airway thing. Or if we feel that this person is landing into anaphylaxis, okay, so in that case also. So over here, the expected course in case of caustic injury or anaphylaxis, uh, in such scenarios, neck hematomas are expected, and again, we are going to go for surgical airway. And another F, finally, the word F over here, F is referral. Okay, for example, if the patient is agitated or is in delirium, and there is what restrained physical examination, like if you are examining the patient and you feel okay, ab examine nahi kar pa rahe, it's not about you are not good enough. It's just that it's very difficult to examine. It's becoming very difficult. The vitals are extremely unstable, and it's very difficult to even see anything. Like matlab, you cannot see that. You cannot have any finding. In that case, it is called as restrained physical examination. It is a harbinger to fatal condition. Now, partial airway obstruction is not an indication for airway protection in emergency department. We need to encourage coughing. So it's only the total airway obstruction that is an indication for airway protection. But if it's a partial, then we are going to encourage coughing in people. Now, difficult intubation. What is difficult intubation? In difficult intubation, the mnemonic for difficult intubation is lemon. Okay, this I read in anesthesia as well. L is to look externally. What? There can be maxillofacial injury, there can be neck abnormalities, and there can be obesity. Then E is evaluate 332. What is 332 is three patient fingers should go inside the mouth both vertically, like between the two incisors. Okay, so this is normal. Then another three is the chin and the hyoid bone, the distance. Chin and the hyoid bone that forms the floor of the mouth, that distance should be 3 fingerprints. And then the thyromental distance, that should be 2 fingers. Then M is the Malampati scoring. Malampati scoring is like That is considered to be the bread and butter of anesthetists. So everybody knows that. So 1, 2, 3, 4. One may the mnemonic is push, then you are going to cancel one letter from the beginning. So second will be push, third will be sh, and fourth will be h. I hope every word is clear. Over here, P is palate. Oh, sorry, P is a pillar. That is the anterior pillar and the posterior pillar. U is uvula. S is soft palate. H is hard palate. Okay. Now, moving on again. Then, yes, lemon में O is obesity, and O it is also obstruction. Okay. So O is obesity and O is obstruction. Okay. So and N is what? N is neck mobility. Okay. So anatomically difficult airway assessment by Lemon is very time consuming. So we anticipate all the airways to be difficult airways, and planning for failure is important. Now see, if you are going to begin looking for lemon thing in the emergency, then the patient might collapse. Okay. So this anatomical difficult airway assessment is practically not done. It's only for the theoretical purpose. So any airway is considered to be a difficult airway. Okay. Now, physiological difficult airway is HOP. HOP is what? H is hypotension. These are called as HOP killers. Okay. Now, anatomical हमने बता दिया, that was lemon. Now we are going to hop with that lemon. Okay. And that lemon is going to kill you. So that is HOP killers. It's hypotension. It's O2 problems like hypoxia, and P is the pH, that is acidosis. So hypotension, hypoxia, that is why oxygen problems, and pH or acidosis. So these are the things that kill a patient generally. Okay, so this is the end of the first lecture of emergency medicine that I attend. Then another is hypotension is not equal to shock. So please don't hypotension. Anyone can be hypertensive, but that doesn't mean the person is landing in shock. A very stupid point to discuss, by the way. Then cryptic shock or occult shock. Cryptic shock or occult shock, it is going to precede hypotension. So uh, before hypotension occurs, there is some hidden shock that is called as cryptic shock. As the word says, cryptic means it is hidden, and occult means also hidden. Occult sciences, occult arts, are all these hidden arts. Okay. Now shock. What is shock? Hypovolumic shock, cardiogenic distributive, obstructive septic. Hypovolumic में there will be loss of volume. Loss of volume होगा तो क्या होगा? Cardiac output is going to decrease. There will be hypoperfusion. Okay. Then another thing is cardiogenic shock. Cardiogenic shock can be due to failure of the pump. Now pump failure can be primary or secondary. If it is secondary, then it will be a forward failure or it can be congestion. Now what is forward failure? Forward failure is going to present with hypotension. Matlab, from aorta, the blood is not able to pump outside, and congestion is that if congestion is there, then it means that one is not able to maintain the volume. So it can be right heart failure or it can be left heart failure. In right heart failure, there will be systemic circulation में हो सकता है, or it can be in edema, or it can present with edema. Whereas left heart failure, it will be in the lungs. I think I messed this up. Actually, left heart failure should be systemic circulation and right heart failure should be lungs, and it is going to present with edema. Okay. Then, okay. So this is, and distributive shock. Distributive shock is what? Loss of vascular tone. The vessel has no tone now. So example is neurogenic shock. So neurogenic shock is an example. And anaphylactic shock is also an example, because in that there will be, if there is no tone in the blood vessels, there will be pooling of blood, and if there will be pooling of blood in the peripheral venules or veins, then there will be decrease in the venous return and there will be Okay, yes, decrease in the venous return, and as such, patient might land in shock. There will be less filling of the blood, less filling of the blood, so less distribution of blood, and so on and so forth. Then obstructive shock may cardiac tamponade. It can be massive pulmonary embolism, tension pneumothorax. All this can be due to obstructive. And another type is septic shock. Now, uh, JVP, decrease in JVP. So, what do you think? JVP will be decreased in what? JVP will be decreased in cardiogenic shock, and it will also be decreased in no. JVP will be increased in cardiogenic and obstructive shock. We have heard about this, and in some cases in distributive also. But it will be decreased in hypovolemic shock, in septic shock, and in distributive shock. Okay. So now unstable bradycardia. Unstable bradycardia, hyperkalemia, MI with complicated bradycardia or cardiogenic shock, hemorrhagic shock, hemoperitoneum, vagal will be stimulated. Trauma patient में bradycardia plus hypotension. The patient is going to present with neurogenic shock, hypothermia, myocardial depression, all this. Slowing of heart and also hypotension. So the thing is, these are just the manifestations of shock. Okay. Now, toxicological causes of hypotension and bradycardia and shock. So, what are the toxicological causes? Paste is the mnemonic for this. Paste, hypotension, bradycardia, shock. Paste में P क्या है? Poppy. It is poppy and propanolol. Propanolol is a beta blocker. Okay. So propanolol and poppy is one thing that can lead to. Poppy is papaver and it's often abused. Then ACE, acetylcholinesterase inhibitors, or organophosphate, carbamate, all these. And calcium channel blockers is CCBs, clonidine, carbon monoxide, cyanide, all this will be come under the category of PAC. E and D में E is ethanol. It's a sedative, yes, sedative. Ethanol is sedative, but yes, the other sedatives can also cause it. Hypnotics. D is digoxin or like oleander. Tricyclic antidepressant, it has an anticholinergic effect, and therefore cholinergic leads to what? Brady. Anticholinergic leads to what? So tachycardia. Now normal saline. Now before studying normal saline, let me just talk about fluids. Fluids can be crystalloids and colloids. Crystalloids are always the preferred. Now what is the difference between the two? It is the osmotic molecules. The difference of osmotic molecules. So osmotic molecule is more in the colloids, whereas in crystalloids it is less. Okay. So osmotic molecules, they are more in colloids and less in crystalloids. So ringal lactate, normal saline, plasmolite, these are all crystalloids, whereas colloids जो होते हैं, they are gelatin, HSS, the Heta starch, I remember I studied in surgery, blood products, and albumin. These are all having more osmotic molecules. Now, crystalloids, they are considered to be the fluid of choice, as I said, and colloids, they can lead to coagulopathy, renal failure, transfusion-related infections. They are even costly, and allergy can be there due to gelatin. Now, ringal lactate is also called as the balanced salt solution, and it is always preferred over NS. And why? Because NS ka osmolarity is 154 milliequivalents per liter. Okay, and it contains only sodium and chloride. So this can lead to what? Hyperchloremic metabolic acidosis, and it can also lead to normal anion gap metabolic acidosis. So this is going to precipitate AKI or renal failure. Now, if difference between sodium and chloride is 24 to 28, तब तो it is सही है. मतलब तब तो drug is तब तो whatever crystalloid that you are injecting is good enough, like 24 to 28. पर इन दोनों का osmolarity में if the difference is less than 24 means it is acidotic. If it is more than 28, it is alkalotic. So that should be there. In normal saline, this difference is zero. Now, if this difference is zero, matlab, I've said the cutoff is 24. If it is less than 24, then gaya. Then the difference, and that is why it is highly acidotic, so it can lead to NADMA. जबकि ringer lactate में sodium is 130 and chloride is 109. So if you subtract, what do you get? 10 less than 9 गया एक बचा and 21. So that is the 20. The difference is 21 to 22. And there is no, so that falls. It is also acidotic, but it is not that acidotic. No, it's only, the difference is less. Now, initial volume of resuscitation in patients of hypovolumic or septic shock patients should be what? 20 to 30 ml per kg of what? NS. NS in hypovolumic or septic shock. Kidney or liver issues or patients or patient is edematous or he is elderly, in that case, अगर किडनी का प्रॉब्लम है, liver issues हैं, patient is edematous, in that and is elderly, we are going to decrease this dose of 20 to 30 ml per kg. Now, early goal-directed therapy. What is early goal-directed therapy? Early goal-directed therapy in patients of severe sepsis or septic shock. Okay. This earlier, what was the old concept? Old concept in 2001 was given by Ryans et al. It's only of historical significance. I wrote it considering maybe it's important. Okay, maybe they give an option in which they say what are the things in new, all except type things, and they give one of the earlier options. So that is why I wrote this. Okay, MAP more than 65 mmHg is mean arterial pressure. How is it calculated? 2/3 of DVP, 1/3 of SVP is equal to MAP. CVP greater than or equal to 8 to 12. Okay. SCVO2 more than 70, urine output more than 0.5 ml per kg per hour, hematocrit more than 50%. What was the main criteria of all this goal-directed therapy के इतने सारे points? What it was doing? It was providing mortality benefits. Okay. Then we came up with a new thing, and in this we thought that targeting central venous monitoring is not useful, and central venous pressure like SCVO2 इसका कोई role नहीं है. So we should only go for a MAP and also urine output. So now only MAP and urine output is seen, बाकी सब की जरूरत नहीं है. Along with lactate, yes, lactate is seen because it is an important parameter of hypoperfusion and shock. So hypoperfusion and shock रहेगा, so lactate can be just seen. Now lactate is greater than or equal to 4. If lactate is greater than or equal to 4, then it's a bad sign. Okay, so if we see that there is a falling trend in the lactate, like from 4 to 3 to 2 to 1, then that means it's a good prognosis and lactate clearance should be monitored. But now this lactate actually replaced the central venous monitoring. Earlier we were using central venous monitoring. Now we also found out that the bundled approach, it also doesn't improve the mortality. Now bundled approach did not explain as such or what is bundled approach, but maybe they talked about even the same thing. CVP and SCVO2, they are now out, as we have said earlier. Now contrast allergy. Sometimes you are giving contrast to the patient. Any abnormal hypotension, then that means that the patient is going into anaphylaxis. If there is a suspected, yes, the patient is going or might go into anaphylaxis. Okay, so first is skin and the mucosa. Skin and mucosa will come under one. Respiratory, there can be dyspnea, stridor, wheezing, anything. Shock is not necessary to diagnose anaphylaxis. Yes, shock can occur. I mean, anaphylaxis can occur without shock because, as we said, there should be only two systems involved. Any two system, more than two systems. तो हो सकता है that respiratory system is not involved or circulatory system is not involved.